Okay, thank you so much. Excuse my bad English because in Morocco we speak more French than English, but there is no problem about that. Thank you. So, in introduction, the integrity of the uterine cavity and its endometrial lining are crucial for embryo implantation and development. Miniaturization of hysteroscopy equipment for both diagnostic and operative, improvement in imaging, and safety of distension media. Embryo implantation, as you know, is a complex phenomenon that depends on embryo quality, endometrial receptivity, and integrity of the uterine cavity. Intrauterine lesions that can interfere with fertility are divided in two categories: major lesion, large intracavitary or submucosal fibroid, uterine malformation, or minor or small lesion, moderate synecia, polyp, chronic endometritis, and from time to time, it's possible to have association in the same patients. The intrauterine pathology is, we can find endometrial polyps, fibroid, uterine synecia, uterine septa, endometritis, or osseous metaplasia or bone metaplasia. As you know, the new classification in uterine fibroid, 012 intramicus or 3-4 in myometrium, or subserosal 6 and 7. Two major parameters: location of fibroid and the size of fibroid. Subserosal fibroid 5, 6, 7, lethal or non-inferior in infertility, especially in less than 7 centimeters. For interstitial fibroid 3 or 4, lethal influence in if they do not deform the cavity, especially if less than 5 centimeters, or if deformation of the cavity, yes, there is a problem here. As you know, submucosal fibroid in hysteroscopia with dissection of fibroid. Effect of fibroid on fertility: submucosal fibroid type 012, lower pregnancy rate, and compared to control infertility cases, lower implantation rates. Does the fibroid affect the prognosis in IVF? Yes. If submucosal 012, if intramural 3, 4, 5, more than 7 centimeters and deforming the cavity. Here there is, yes. And the resection of big fibroid here, submucosal, about 7 or 4 centimeters, as I do in my center. We have to see always the electrode. There is little bleeding here, so very easy. You can have hemostasis. And we can go away all the fragments for that. Another one. is anterior, that one. Now we have to go in the other side. Work together with my friend. Okay. And the recommendation of French experts, hysteroscopy is recommended in the evaluation of the intracavitary impact of fibroid. In the absence of other infertility factors, it's legitimate to perform hysteroscopic myomectomy. And there seems to be an improvement in pregnancy rates after myomectomy in the case of submucosal fibroid type 012. In IRT, it seems that the presence of submucosal or interstitial fibroid deforming the cavity leads to a reduction in the pregnancy rates and should be removed. For polyps now, often overlooked ultrasound in the pre-operative period, 7 or 27 of infertile patients have polyp, but what are the responsibility for infertility? And improvement in infertility after resection, but from what size? 1 centimeter, 2 centimeters, 3 centimeters, 0.5. We have to discuss about that. In ultrasound, as you know, all we can see that. In ultrasonography, we can see that. Should the endometrial polyp removed in infertility? I think yes. But be careful of hysteroscopy complication, infection, perforation, cervical traumatism, and synestia. Polyps and infertility, randomized trial to 215 patients undergoing intrauterine insemination, removal of intrauterine polyps versus endometrial biopsy alone, and as you see here, pregnancy rates is better when it is resection polyps. Some pictures for polyps. I don't know if you have a shaver, if you use that, but I begin to use that. It is very, very easy. Another one. And lots of polyps inside the cavity. Whichever, it's more easy, but I think it's more expensive too, to use that. But it's more easy because you can remove all the debris for polyps. For septa now, uterine septa, patients with uterine malformation, 6 or 9% of infertility cases, with septa to 35% infertility, but many septa are overlooked. The septa endometrium has poor receptivity to steroid hormone and very high rates of miscarriage. In explain infertility, pregnancy rates 43% for the group of patients with septum resection, and if there is no resection, just 20%. For first trimester miscarriage, 60% if no resection, and 11% after resection. And for live birth rate, 35% if resection and 8% in the group without resection. Look, I think the resection is more better here than no resection. Per transfer, before septum resection 2.7%, after resection 15%, and 20% for the control group. Some pictures for septa. For synestia, obliteration, as you know, we can define obliteration of all of parts of the uterine cavity and or cervical canal by no physiological adhesion of two surfaces that are normally smooth and independent. Postoperative adherent pathology or direct impact of fertility prognosis. The diagnostic of synestia is by hysteroscopy. allows direct inspection of the cavity and evaluation of presence and location of synetia, the extent of synetia, the degree of synetia, and the quality of the endometrium. Some pictures here. The objective of the treatment: restore the size and the shape of the cavity, allow endometrial regeneration, prevent recurrence of synetia, and restore fertility if necessary. The treatment, hysterosapangography, extent of synetia and tubal potency. For hysteroscopy, mucosal or fibroid, fibrous appearance of synetia, extent of synetia, adjacent endometrium, and removal, we can remove of synetia. Pregnancy rate 32%. For tuberculosis synetia, we have a loss of tuberculosis in Morocco. See frequency in our region, endometrial destruction with tuberculosis. The treatment mechanic, we can do that with rigid hysteroscopy or scissors. Use of monopolar energy with Gynaecological, but for the moment just bipolar energy with physiological serum, distension media. Sometimes several procedures are needed to obtain an adequate cavity, and sometimes adhesiolysis is difficult to perform if the synetia are severe and extensive. It's the most difficult, I think, it's the most difficult procedure of hysteroscopy is synetia. Some pictures. Here I have how to do that with the monopolar or bipolar, but now more bipolar than monopolar because we had a lot of problems with Gynaecological. Now we can use just physiological serum. It's better. I think at the beginning it's not possible to do the synetia because we have to give an entraînement for that. We have to see 2 ostium without any synetia, and it's okay after. But we have to do more carefully not to perforate the cavity. We have seen some complication for that, digestive complication and ureteral complication. So we have to be more careful for that. Slowly and step by step. I think it's enough. And to obtain hemostasis after the procedure. Here another one with just scissor. You look the synetia here, and when it is not very fibrosis, we can do just scissor, and it's finished. Oh, excuse me.
You have one more minute.
Okay. For the prevention, the best management of uterine synetia is to avoid deformation and or reformation. Diagnostic, when we do that, we have to do hysteroscopy diagnosis 6 weeks after operative hysteroscopy. Or if you have halo barrier, it was very good to use that. I have a little for halo barrier, little film for that. To avoid constitution or reconstitution for synetia. I begin to use that, but it's very expensive, yellow barrier. But after, it's very, very kind and very good if you can use that, or 6 weeks after, we can use hysteroscopy, diagnosis hysteroscopy for latest inertia that we can find. Okay. For endometritis, congestive endometritis, concordance between hysteroscopic appearance and histological confirmation at around 35%. The germs, chlamydia or Escherichia coli or mycoplasma, and the rate of chronic endometritis in infertility in the literature varies on between 2 and 40%, 46%, 15% in Clamart in Paris, 17% with Belaïch-Allard in Sèvres, and 20% in Cicinelli. Association with infection, mycoplasma, and chlamydia, possibility of association, sympaginitis, and cervitis. Interest in treatment chronic endometritis, 45% in pregnancy for Friedman, 44% for Mergui, and 40% at Sèvres. Now, if there is embryo implantation failure, can we do hysteroscopy? I think yes, we can do that because it's important for hysteroscopy significantly increase the chances of success in the following IVF cycle. And the result is confirmed even if the hysteroscopy was only diagnosis because the uterine cavity was normal. Donc it's better if there is embryo implantation failure to do hysteroscopic diagnosis after that for 1 or 2 failure implantation. Bénéfique, donc diagnostic efficient and concomitant treatment when pathology is present, may facilitate embryo transfer, benefits traumatism of the endometrial scratching. For osseous metaplasia, it's better to do hysteroscopic too, and for uterine hypoplasia, I think it's better, and we have interest of hypoplasia, and we can have more pregnancy after that. Thank you so much.
Thank you, Dr. Syed Lazrak.